As Dermot said, I'm going to talk about the HPV vaccination programme, and just to state first, I don't have any conflict of interests. What I intend to talk about is the process in decision-making in immunisation in Ireland, look at HPV vaccination from the school programme we are running currently, how it's working in other countries, and also to talk about the inclusion of boys. So in terms of immunisation in Ireland, as Jim had mentioned, there's a National Immunisation Advisory Committee, which is an independent expert committee of the Royal College of Physicians of Ireland. It's comprised of a number of experts, mostly medical, but there is also nursing representatives. And this committee advises the Department of Health and produces the immunisation guidelines for Ireland. They're based on the best evidence regarding the safety and efficacy of currently available licensed vaccines, looking at the disease burden and increasingly looking at including a pharmacoeconomic analysis, particularly when any new universal programs or any increase in a large target audience is recommended. It should be noted that some of the recommendations that are recommended by the expert committee are not implemented, perhaps due to financial constraints or other issues. And the HPV programme is a case in point. For example, in April 2008, the advisory committee recommended that the vaccine would be included in a schedule for all girls aged 12 years of age. This was supplemented with advice from a HIQA, Health Information Quality Authority, Health Technology Assessment, that the vaccine was cost-effective for 12-year-old girls, and HIQA also recommended a once-off catch-up programme for 13 to 15-year-olds. That was April 2008. And in August 2008, the then Minister of Health made a statement that the programme was to start the following year. In November, many people will remember, in September 2008, we had a fairly large financial crisis globally. And as a result, our Minister of Health at that time said that the HPV vaccination programme was deferred due to rapidly and seriously deteriorating economic situation. Fast forward is being a little bit optimistic. Another year passed, and in January 2010, following quite an amount of political pressure, the then minister announced that the programme would be offered to girls who were in the current first year of second level school and would continue on. And we were then given the task to implement that programme. The aim of the programme is to protect girls from their future risk of developing cervical cancer. And in doing so, we have to provide 3 doses of HPV vaccine to girls before they reach an age when the risk of infection increases and they are at that risk. And our objective was to achieve a vaccine uptake of over 80% for this 3-dose schedule. That's an international comparator that has been used. So in delivering the programme, we had a large number of planning issues to consider. The first was who was going to deliver the programme. And in this, we had a number of options. We could deliver it through our current school programme that is run by our community medical colleagues and nursing colleagues. We could have delivered it through primary care, through GPs, or we could have contracted a third party. And the graph you see beside you shows the impact of the programme that was introduced in the UK, where they had a mixed model of implementation. They had some areas where vaccines were provided by their school teams and some areas by GPs. And whilst the uptake of the vaccine for the first and second dose by GP or by school team was fairly similar, the uptake dropped significantly for GP-administered vaccine in the 3rd dose. So having got that information, and that would have also been supplemented by information we would have had in the past, a decision was taken that this would be a school-based programme run by HSE teams. An additional €4 million was provided to the HSE for this programme. That did not cover all the aspects of the programme which were absorbed from the current HSE budget. But the funding that was provided was to provide money to buy the vaccine, to provide what additional staffing that was needed to look at any information or training needs, and to look at IT. So in terms of the vaccine, at the time and still to date, there are 2 licensed vaccines available. There's the quadrivalent Gardasil vaccine, which protects against 4 HPV types, 16 and 18 and 6 and 11. And there's the bivalent Cervarix vaccine, which protects against 16 and 18. The 2 vaccines are not interchangeable, but in our aim to protect girls from cervical cancer, they were both eligible to compete in a competitive tender process. So following this process, the contract was awarded for the provision of Gardasil as being the vaccine of choice. And Gardasil protects against 16 and 18, which, as we know, cause about 70% of cervical cancers, and also has the added benefit of protecting against HPV type 6 and 11, which cause 90% of genital warts. Both vaccines are a 3-dose schedule. Gardasil is 0, 2 and 6 months. And in introducing our HPV program, we also decided to implement an enhanced reporting of any adverse events to the Irish Medicines Board, because of the fact that there was some public concern that this was a new vaccine and whether it was going to demonstrate a safety profile. That had happened in other countries, but there was certainly a requirement on us to demonstrate that in Ireland also. We also had to look at the aspect of training for HSE vaccination teams. In the past and currently still, they provide vaccines in primary schools, but they are individual vaccines. There's no schedule involved. And this was the first time that school teams were asked to provide a schedule of vaccinations with a very prescriptive 0, 2 and 6 months. So a training program was developed looking at the epidemiology, the vaccine efficacy, updating frequently asked questions. And in addition to that, we also used the principle of a medication protocol. Up to date, prior to that, every vaccine that was had to be prescribed by a doctor. But a medication protocol allows nurses to administer vaccine without an individual prescription under defined protocols. So these protocols were used to provide greater efficiencies with the program. The other aspect we had to counter and to look at was communications. We had a large amount of adverse and, it has to be said, pro-vaccine publicity. But we had to deal with this in as accurate and as informative way as possible. We did this in a number of ways using an onion-based approach. So we start with a very basic information leaflet that is distributed to all parents as part and parcel of the consent process. That is followed up by a website that provides additional information, and on that website there's a facility to ask questions which are answered within 24 hours. There are translated materials in up to 8 different languages, and there are also further websites for further information. We surveyed the parents on the information that we provided, and over 90% of them were happy with the materials. But we also worked very closely with the Department of Education, with school authorities, other stakeholders, and our colleagues in the media. And all the time we had to reinforce the message that whilst this is a very effective vaccine, it only protects against 70% of cancers. And we still need to highlight the importance of cervical screening in the future. And in that regard, we worked with our colleagues in Cervical Check in the National Cancer Screening Programme. In addition, we also had to look at an ICT system. We needed to record which girls had or had not 1, 2 or 3 doses. It might surprise you to know that there's no national ICT immunisation system in this country. There was no school's national ICT system. So for the first year of the programme, we had to record all this detail manually. And any collated figures were then sent to our office to collate a national uptake. Extremely time-consuming for those concerned. So the programme delivery. We were obliged to start some schools in that current academic year. So 21 schools started in May 2010, with full rollout of a double cohort of all those girls who were in first and second year, 60,000 girls, in 575 schools. Those of you who are not familiar with Ireland may not be aware of the fact that there's quite disparate populations, and the populations are scattered into quite small numbers. The table on the right-hand side shows you, and the column even more to the right, shows you the area we're in at the moment, in HSE West. And in HSE West, in the Galway and the surrounding counties, there are 75 schools that in the first and second year, there were less than 30 girls in the 2 classes. Each of those schools had to be visited within a 4-week period. We had to, in order to have a 0, 2 and 6 month schedule, adopt a blitz and mop-up approach, whereby all the schools were visited within a 3-week period. Any girls that missed out had a mop-up clinic appointment given to them to allow us time to go back 2 months later and back 6 months after that. We also have quite a short second level school year, so it was an extremely difficult task to make sure that all the girls were vaccinated. That brings us to the constraints. Obviously, resources in terms of staff and ICT, the communications we've also discussed. We also included girls who were educated out of school or who were homeschooled. And we looked at the issue of medication protocols, as we've talked about. We had, because there had been uncertainty about whether the programme would go ahead, a number of girls who'd already started either this vaccine or an alternative vaccine. So we had to deal with that. We had to deal with the vaccine being given too early or too late, and any adverse events, and all the time reinforcing the cancer screening message. We were fortunate in that Gardasil has an alternative schedule in its licence that it can, in exceptional circumstances, be given at 0, 1 and 4 months. So we were able to utilise that. But in the main, we tried to stick to the 0, 2 and 6 months. And just bear in mind that unlike many of our other country members, speakers today, we're not used to snow. And in November and December 2010, as this photo shows you, we had a large, significant snowfall that lasted for a number of weeks. Schools were closed, and that was the time the second doses were taking part. So not only were the constraints ones we predicted, they were ones we hadn't predicted as well. In monitoring adverse events, we were conscious of the fact that worldwide, a large number of doses of vaccine have been given. To date, it's over 111 million doses of this vaccine. And we knew internationally the side effects were relatively mild, the local reactions as always. 10 to 15% of adolescents will faint as a result of any vaccine, not particularly HPV vaccine, so that needed to be dealt with. Anaphylaxis is very rare. And you will be familiar that there were some coincidental deaths that have been reported. In investigation, they've been found to be of no association with HPV. And when WHO did a review in 2009 and to date, there have been no concerns with the safety profile. Our own Irish Medicines Board carried out a similar exercise in the first year of the programme, which again showed that the adverse events were consistent with the known safety profile. And the Irish Medicines Board provided regular updates on their website of the data relating to any adverse events. So getting to the point, the uptake. In the first year of the programme, the vaccine uptake, our goal was 80%. We achieved 82% for a 3-dose schedule. And what was even more gratifying was that 97% of the girls who started the first dose of the programme completed the 3rd dose, which is a huge credit to the vaccination teams who were involved in the programme. That's the first year of the programme, and our programme has continued since then as a routine programme for all first year, that's 12-year-old girls. But in 2011 we had a change of government, and as part of the programme of government, there was a statement to say that the new government would include a vaccine catch-up programme for all girls in second-level schools. So we had to introduce a catch-up programme for 6th-year girls, that's girls who are 18 years of age, and that was introduced last year and will continue until next year, such that all girls in second-level schools will have been offered the programme. In addition, we were able to introduce a national IT system beginning with last year. It's been a hugely task-orientated issue, but it is in place. And our target for first years, again, 2011-2012 was 80%. And for sixth years, 18-year-olds, we knew our target was going to be less. Internationally, the targets have been in and around 60%. Provisionally, and we don't have official figures as yet, but I'm highly confident that they will be exceeding 80% for our first years, again, keeping up to date with our figures. And our uptake for sixth years, for the older girls, is in excess of 70%, which again is a great credit to the teams involved. Let's look at the situation in other countries. In the States, they've recommended HPV-4, the quadrivalent vaccine, since 2006. They don't have a school-based program, and as was shown earlier, their 3-dose uptake is of the order of about 35%. In Australia, on the other hand, they've had an excellent program since 2007. They have a school-based program, and they also offered a catch-up up to the age of 26. Their 3-dose uptake is about 73%, again decreasing with age. In Europe, the vaccine has been recommended from 2006 onwards. There's now a routine program in 19 out of 29 European countries, with a catch-up in 10 out of 29 countries. And a recent study looking at the situation in Europe has very clearly pointed out that their uptake in European terms has been lower than expected. So we're top of the pile. We've done extremely well. Let's look at the impact of the vaccine, and Australia is very much the place to look. They introduced their nationwide program in 2007, and this slide shows you the diminution in cervical lesions in those girls who are less than 18. They've seen a 50% decline in the incidence of high-grade lesions since the introduction of their program in girls under 18 years of age. Let's look at the impact on warts, because in Australia they've used the HPV-4, the quadrivalent vaccine, since 2007. And in girls less than 21 years of age, where they have an 83% first dose uptake, note first dose, we have an 83% third dose uptake. In 2011, they've seen a 93% decline in genital warts in girls. And in 2011, they didn't see any genital warts in vaccinated women under 21. The other interesting point to see in the second graph is that in men, they've seen an 82% decline in genital warts in heterosexual men, demonstrating what we've talked about earlier, the herd immunity. There's evidence of herd immunity, the impact of HPV vaccine. What about the boys? We've talked already about Gardasil being licensed for the prevention of warts, and it's also licensed for the prevention of anal cancer in the States, in Canada, in Australia and New Zealand. It should be noted that to date, the vaccine license has not been extended to the inclusion of anal cancer in Europe. It's not as yet licensed for the prevention of head and neck cancer, but as was mentioned earlier, we do know that the vaccine elicits the same or perhaps even higher immunogenicity in boys. And again, as been said earlier, the vaccine is most cost-effective in boys when the uptake in girls is low. We know the vaccine could reduce the transmission in men who have sex with men, and perhaps could be cost-effective in men up to the age of 26. Looking at the recommendations for the vaccine in boys, it has been recommended in USA and in Austria, but they have a very different model of implementation, where the cost is covered by the individual recipients. In Australia, they have recommended a national program be introduced for boys in 2013 with a 2-year catch-up. But of interest, the head of immunisation in the UK, David Salisbury, in the Lancet in the Infectious Disease Journal, has made a statement which I think is interesting about the Australian situation. This change to recommend the vaccine be given to all boys seems a conundrum, especially after female-only vaccination has shown a positive effect through herd immunity, and male vaccination was previously not cost-effective. So it's an interesting decision that that Australia have made, and we certainly will watch with interest how the impact is. There have been some modelling studies looking at the clinical benefits of vaccinating boys and girls against all HPV-related diseases, and this study looks at the principles in Europe. It looked at the benefit of adding boys, and they also point out that it was dependent on the coverage in girls. But of note, they noticed that the largest incremental impact would be on head and neck cancer because of the increased incidence in males, that if you added boys to a universal vaccination program, there could possibly be a 66% reduction in head and neck cancer. But we don't have any efficacy studies yet on the impact of HPV vaccine on head and neck cancer. So in relation to HPV vaccination of boys, we've heard very eloquently from all the speakers today about the epidemiology of HPV infection and head and neck cancer. Not just head and neck cancer, we also know about anal and penile disease in men. The duration of protection is another issue that we need to consider. We don't yet know the duration of protection and whether a booster dose will be needed, but we're watching and waiting, and that obviously is an influencing factor in determining whether vaccination for boys should be recommended. We know about herd immunity, that there has been demonstrated herd immunity from girls to boys, but there's also evidence to show that there would be immunity spreading the other way around as well. One of the aspects we need to consider is acceptability. Our message on HPV vaccine to date has been on the impact of HPV vaccine for cervical cancer. That's a cancer that girls get. We need to change our message, and we'll need to inform the general public and medical and health colleagues about the impact of HPV disease on other cancers. And there's certainly a lot of work to be done in that regard. The cost is a huge issue in determining whether we prescribe universal vaccination. And in that regard, there are some studies looking at whether a 2-dose schedule would be enough. The jury is still out on that as yet. And there are societal and ethical considerations. If we say we're vaccinating girls and we have a herd immunity impact for boys, what about men who have sex with men? Are we discriminating against them? It's not possible to identify that group at 12 years of age. Or should we have a targeted program for men who have sex with men outside a universal program? And as we've said, there is evidence to show that it is cost-effective for men who have sex with men up to the age of 26. But how and when they would disclose the fact that they are homosexual, and there is some evidence to show that they may disclose at the age of perhaps 20, at which stage they've already perhaps had up to 15 partners. That's an Australian study that's been done recently. So these are issues that need to be considered when a decision will be made on the vaccination of boys. We also have competing interests in immunisation. HPV vaccine is not the only vaccine. And if we're looking at vaccination strategies, we have to look at the fact that there's now a new meningococcal B vaccine that's been introduced that is certainly being considered for inclusion in Ireland and in the UK, which has the highest rates in the world of meningococcal disease. A shingles vaccine is being introduced in the UK for all those aged 70 with a catch-up from September. There will be pressure on Ireland to do the same. The UK are introducing rotavirus vaccine, and they're also introducing a universal childhood flu vaccine. So there are competing interests in vaccination strategies. We don't have enough money to do all the vaccination programs. Never mind the money to buy the vaccine, we also need to look at the schedule. We have a relatively busy schedule within the schools already. We're probably going to introduce a meningococcal C booster into schools. If we add in boys, it makes it extremely busy. So we need to look at the impact and the feasibility of doing all these programs. So in conclusion and in next steps, we need more evidence. We need the impact of the vaccination on boys. We need efficacy studies on the prevention of HPV-related cancers, particularly head and neck cancers. We need our expert group to review the addition and the inclusion of boys in a universal recommendation, whether they introduce a permissive recommendation, and then we need to get to the implementation stage, and there's often a gap between those two. In summary, we've introduced an excellent, I would say, HPV vaccination programme for 12 and 18-year-old girls. We know the vaccine is safe and well tolerated, and our vaccine uptake has exceeded the target. We've already seen internationally an impact on the HPV-related infections and precancers, and herd immunity has also been demonstrated. And finally, I would like to acknowledge most sincerely our HSE vaccination teams and our other colleagues who have contributed to the success of the programme to date. Thank you.